Hello and welcome to the Spinal Cord Injury Forum. My name is Jeannie Hoffman and I'm a clinical psychologist in the Department of Rehabilitation Medicine and the director of the Northwest Regional Spinal Cord Injury System here at the University of Washington. Tonight we are very excited to have occupational therapist Julie Grant and physical therapist Jill McVey, who will be talking about revolutionary shoulder care for spinal cord injury. Take it away.
All right. And just so you know which is which, this is Jill McVey.
And this is Julie Grant. And this is Revolutionary Shoulder Care. We chose this name not only because we honestly can't resist a pun, but we do want you to think more revolutionarily, more outside the box about shoulder care. Less TheraBand exercise and more seeing the forest from the trees. So what we're about to present is the result of a lot of research, but also a combination of several decades of our clinical and personal experience. And because we've had years and decades to assimilate all this information, unfortunately, y'all have 90 minutes to keep up with us. The point is, we're sorry. But also, the purpose of this presentation is to not force you to learn everything that we think we know, but for us to help take you through this guide that we've created for you and give you the most recent evidence about shoulder management for people living with spinal cord injury, as well as obviously giving you our opinion as well. Here's our objectives, which you can read. So we're going to talk about thought patterns, emotions, how that manifests in self-care or perception of pain, talk a little bit about seating and aspects of wheelchair use that might be playing into shoulder symptoms. And then we'll talk a little specifically about what controlled mobility is and the difference between basic mobility and flexibility, and lots of other things. Now, no good relationship is solid without some good ground rules and boundaries. So here are ours. Firstly, neither of us are selling any products and we don't have any conflicts of interest to disclose. Secondly, and possibly most importantly, the search for truth is messy and it's difficult and it's long. And what I mean by this is we are always trying to attempt to discover the real absolute truth about anything. In this case, we're attempting to discover the true answer to the question, what constitutes a healthy shoulder complex? And in doing so, we're drawing on years of research through a seemingly objective system, being the scientific method, but unfortunately that scientific method is operated on by humans who are imperfect and biased and quite honestly not that good at math and statistics. Additionally, each experiment that's published and accepted for publication, no matter how well run, no matter how well the methodology, only adds a teeny bit, a tiny sand granule of evidence to the overall picture in our whole total search for truth. This is why our understanding of constructs and truth itself sharpens and changes over time as we add these little bits of information that get us closer to potentially that absolute truth. Our understanding and perception of those constructs will change. So if tonight we give you some information in this presentation that might seem a little strange or flies in the face of what you believe to be true, we're not here to call your baby ugly. But we are here to expand your knowledge base and help you get closer to your own absolute truth so that you can be more successful and proactive in managing shoulder health. Finally, and this is probably pretty obvious, this is no one's personal therapy session tonight. So if you or someone you love has longstanding shoulder pain or pain anywhere else for that matter, seek specific intervention and don't let us two randos tell you what's best for you, and when we're talking in very general terms. We good? Good boundaries? All right, let's fly. All right, this is a perfect summary, this slide, of our entire presentation. Everything you need to know about the shoulder, in the broadest of terms, is summarized by this statement. Shoulder function is a reflection of movement system wellness. Nicer way to say it is, it's not always about the shoulder, and it's not only about the shoulder. Pain doesn't occur in a vacuum, and so you can't address treatment in a vacuum either. We need to understand comprehensively all factors and forces that can act on the shoulder. So if I just spent a minute pontificating about the search for truth, we do need to set, if I'm going to be consistent with myself, a common framework for communication. We need to all be on the same page about what the shoulder is actually part of and what pain actually means, which is very difficult to define. So, the shoulder is attached to the human movement system, which is the body. The body is the integration of every body system, subsystems that generate and maintain movement. This can include the biomechanical system, which is our bones, joints, muscles, connective tissues, our cardiovascular system, our neuromuscular system, and our organs. It all counts. The system itself is influenced by social, environmental, and personal factors, which I love just even saying that, because a couple of years ago, physical therapists at least weren't talking too much about the biopsychosocial framework and really talking about the cultural factors and the social factors and our belief systems that contribute to our prognosis as patients. Now, this year, the American Physical Therapy Association has actually included the language on the second bullet point about our personal factors, our social factors, and environmental factors as included in the definition of the human movement system. So now it is officially part of our definition, and we're moving away from more arcane medical definitions of what the human body means. This also introduces a lot of different factors at work on the human movement system. And if any one of these systems or factors is dysfunctional, it can affect the entire system as a whole. And if that dysfunctional part or parts is let run loose for a long time, pain is more likely going to be the result. So therefore, if you're going to keep your movement system happy, or any of the appendages attached to it, that means you got to keep everything happy within what you're able to control through your entire lifespan. Wellness is not a discrete moment. It is a constant search for better. And we do that through challenging and variable experience. The literature is pretty unequivocal about this. Another way to say it with my patients who want to rehab their shoulder, and they want to do the same old exercises that hurt them, I say, well, there is no Major League Baseball pitcher in the world that rehabs a rotator cuff by throwing more. So that's what I mean by variable. And we'll go into this a lot later. It's a bit of a small soapbox. So that's the human movement system, and again, broad terms. Pain, broadest terms possible. This is the best definition that we could find, which I think is a pretty good definition since pain is an entirely subjective phenomenon, and being able to capture what pain means as a subjective phenomenon is incredibly challenging. Pain is best conceptualized then as the result of a complex interaction of biological, psychological, social, and cultural factors that shape perceptions and response to musculoskeletal pathology. And there's a lot of jargon there that actually kind of mirrors some of this. So there's a little crossover there, which I think is kind of interesting personally.
All right. So shoulder pain is not just about the shoulder, and I hope you've realized that by now from some of the stuff that Jill has shared. Do you think symptoms are influenced by the diaphragm, by emotions and beliefs, by your social life, by past experiences? And the answer is yes. Habits, roles, routines, the environment, all are influenced by pain, and pain influences all of them. And this language should sound similar to occupational therapists because ideas presented in the occupational therapy practice framework use a similar language. OTs have known for a long time that everything is connected to our well-being, with modifiable and non-modifiable factors influencing outcomes. And we need to look at the whole system, not just part of it.
Can I intro this slide real quick?
Mm-hmm.
We have a couple slides that have these quotes. Don't confuse this for a motivational poster. This is not us trying to be rah-rah encouraging. We're taking quotes from the masters of coaching and training and psychology, and we're giving you a little taste of an author that maybe you might want to read up on more when it comes to your own mental game or your own physical game. So look for John Wooden's name as well as other names at the end of our section, or the very end of our talk, under additional reading.
All right, so on this slide we have factors that can influence pain and function. And we're going to talk about these in various levels of detail, but they're all important and they're all modifiable, and some you can even work on starting tonight. Fear is a problem, and it's a lot of problem when it comes to pain. Fear avoidance patterns can be really problematic both for function and for pain. And so some researchers looked at psychosocial factors that influence activity levels and outcomes. They identified catastrophic thinking, kinesiophobia, and fear avoidance. Catastrophizing is when the threat level of pain sensation is magnified, and kinesiophobia is fear of movement. These are both associated with heightened pain and activity limitations for everyone, even active wheelchair users. And I'll repeat that. Fear avoidance impacts everybody. These are all factors that clinicians can screen for, and they significantly affect rehabilitation outcomes and function. And this is the same researchers. They looked at a study of just looking at manual wheelchair users. They were all considered active. The problem with the study was they did not define what active means. I wrote that in big letters across the top. I was like, what is active? But we used their information anyway because they did have good information, because they realized that it impacts everybody. But they found a connection between pain catastrophizing, reduced activity, and pain. And those reduced activities included both like sports as well as work and volunteer work and anything outside the home, and also maybe a little less impacting at home. They had a variety of reasons what they thought. But their main conclusion was that there was a need for multidisciplinary care to address these psychosocial factors, because sometimes that's left out, like somebody doesn't address that. And then our response to negative suggestions and anticipation can impact our experiences. And many of you have probably heard of a placebo, but do you know what a nocebo effect is? And its expectations of a negative outcome can induce the worsening of symptoms. And like that's to the effect where a negative verbal suggestion can actually release hormones in your body that can make pain worse for you. Like, how powerful is that? And so part of the reason I put this in is so that clinicians and family members and friends will be aware of the power of their words and not say things that can actually make their significant others or their patients feel worse. Even motor performance can be impacted by nocebos and placebos. Again, that positive negative expectation. So some of this starts to sound motivational speaking, and we don't mean to be, but that's what some of this is. And self-efficacy. And some of this is going to sound a little corny to the pessimists in the room, but believing in your capacity to do something can actually impact your performance. Those with higher self-efficacy were able to complete more tasks and had greater ratings of physical functions than those who had low self-efficacy. And that's important to mention. Feelings of self-efficacy impacted effort given, amount of stress experienced, and how hard someone persevered towards challenges. So this is really important, both initially in rehab and then just the challenges that anyone with a spinal cord injury faces in their life. And probably true for even if you don't have a spinal cord injury. So how do you resolve negative thought patterns? And we recommend through empowerment. We recommend that clinicians use the biopsychosocial frame of reference in their services. We recommend that patients seek multidisciplinary care. Multiple studies we reference pointed out that this is important. And that can include OTs, PTs, physiatrists, psychologists, and probably a combination of, and it will differ depending on what you need at the time. All of the clinicians mentioned, though, should be able to teach their patients about cognitive factors that influence their pain and the outcomes. And additionally, activities during physical rehab should challenge those thought patterns and help people understand what they're really capable of, because that fear avoidance and catastrophizing can really get in the way. All right, we're going to take a look at some of the modifiable factors that we can work on that are related to wheelchair use. And this is a pull out from that bubble diagram that we had earlier. We chose these 4 because these are the factors most frequently associated with shoulder problems across the literature that we reviewed. They didn't always understand the mechanism of how the problem happened, but they came up a lot. All right, wheelchair seating and positioning, super important. Being in the just right position to push is very important. Most people have a tendency to sit with their pelvis in posterior tilt, which increases kyphosis, which is that kind of hunched over upper body position. and doesn't put the shoulders in an optimal position for pushing, reaching, or transferring. And the position described in the slide requires the least amount of effort to maintain because the spinal curves are stacked on top of each other, and it's easy to move from. And the research shows that a really stable position is just that, it's stable, which means that it's hard to get out of. So when you need to move and do things, you're stuck in this position. For those with reduced trunk stability, this isn't necessarily going to be the most stable position, and you'll have to practice holding onto your chair when you reach for something. But the benefits for your shoulders are worth that effort to move. And things to look out for include too tall of a backrest and too long of a seat depth, because both of those can encourage that posterior tilt. You'll see some familiar names if you're in this company, but the goal is to have the push rims easy to reach, and the axle position is really important for that, while maintaining joint alignment and with weight centered over the rear wheels. And I recommend seeing a seating therapist, an OT or a PT, to help get the best position possible. And there are many ways to customize modern wheelchairs to fit the best user, or fit the user best, actually. These are just the most frequently mentioned in the literature and the easiest to generalize. There's lots of tips, but that would be an entire wheelchair seating talk. And so we have to just kind of touch on these. Next, we'll talk about propulsion technique. And I'm not going to talk too much about it because there are a great series of videos on the website. Make sure you check out that link. They demonstrate pushing on all kinds of terrain with explanation to optimize your technique. But mostly in literature that I read, it mentioned reducing stroke frequency, so not little short, quick, darty pushes, but long, smooth strokes in an oval-shaped push pattern with a recovery stroke where your hand drops down. And so that gives your arm just a little bit of a break and resets it into the right position. Transfer technique. Better transfer technique is correlated with less shoulder pain during transfer. And again, better. What does better mean? But researchers use the transfer assessment instrument to rate transfer technique, and those with better scores had less shoulder pain with transfers. It's important to note, better transfer techniques may help those with higher level injuries who have upper limb mobility and strength limitations. And so essentially, you're going to try to use really good technique to reduce the effort required to transfer successfully and safely. Again, there are some really great videos on the SCI Empowerment page, so definitely check out those videos. And pressure relief. Nearly every source we reference discussed this. And I think most people here probably know this already. I think it's out of date to do transfer relief by pressing straight up, but you never know, so we wanted to include it. But we recommend weight shifting by either leaning all the way forward and then all the way to each side laterally. And the high joint forces happen in the shoulders when you do press-ups. So we don't recommend that for weight shifts, especially when you need to do frequent weight shifts. That's a great position to be in. All right, and now Jill is going to talk about movement, fitness, and sport.
Thank you. All right, so we're back to our John Wooden quote page, and we're moving away from our wheelchair seating and mobility bubble, and we'll be camping out in the exercise and movement bubble for nearly the duration. So buckle up. We know that movement, particularly movement under load with a weight, does awesome things for every human movement system. It keeps our joints healthy, it keeps our soft tissues flexible, it balances our muscles, it sharpens our brain's image and perception of our body, which in and of itself reduces pain sensitivity. The very active movement reduces pain sensitivity. It gives our cells nutrition, it increases circulation, it facilitates tissue repair. It makes every system stronger. I'm also a person that sells movement, so consider the source. However, the issue in talking in broad terms about movement being medicine is we need to consider what constitutes therapeutic and healthy movement for a population that's varied and diverse, like spinal cord injury. And when we consider that, it's immediately apparent that there's a thin line between balancing use of the upper extremities for weight bearing, mobility, and other daily tasks with using the arms to get enough beneficial activity and the right kinds of activity to maintain optimal movement system function. My goal for all my patients, and honestly everyone in the world, is to be healthy enough to participate in sports or similarly demanding activities, because again, the human movement system is strengthened by challenge. but no one starts at the Olympics. Before we get to sports, we need to be able to get all of our subsystems that contribute to movement firing on all available cylinders. Before we do that, we have to be able to move our body under load. Before we do that, we have to be able to just move through a pain-free, fully available range of motion. So we're going to start with mobility, because without mobility, you don't have much of a foundation. Now, before we get into this too deep, when I talk about mobility, I'm in this moment not making a lot of distinguishing characteristics between passive mobility, as in movement of the shoulder that someone does for you, versus active mobility, movement that you do yourself. It's all the same when it comes to motion. Okay? The act of moving, no matter if you're moving or someone's moving you, is healthy for you. Maintaining full, pain-free overhead shoulder motion requires a lot of things to go right, especially in a complex that's as mobile as the shoulder. It requires a coordinated effort between your arm, your collarbone, your shoulder blade, your trunk, as well as the muscles around this area have to allow that motion. Maintaining all this full range of motion, as I said, lots of benefit. And additionally, because this is a ball and socket joint and therefore there's a lot of spin of the ball relative to the socket, we need to have balanced muscle forces working across this joint so that spin results. If this is knocking around the socket, that's where we get impingement and rotator cuff and biceps tendonitis and all sorts of other diagnoses that we're not going to stress about today. We can just say pain. We need to distinguish whether we're doing this for self-care or we're caring for someone else or we're a therapist, of whether a joint, whether restriction in range of motion, total range of motion, my ability to get my arm overhead, is due to problems with the joint surfaces moving, mobility of the joints, or flexibility, stretch of the muscles, or a little bit of both. Mobility in and of itself, moving for movement's sake, is good, but controlling your mobility, distributing your mobility across all available segments is better self-care. This is also one of my favorite slides, because this quote will never lead you wrong. In 19 years of practice, I fall back on this again and again and again when I'm trying to figure out, why does this person in front of me hurt? When I watch them move, if I raise overhead and it hurts, I watch them move overhead and I see what's moving too much, what's out of control. Because something that moves too much over and over and over and over again is going to break down. In mechanical systems, movement occurs along the path of least resistance. So if you're going to address a range of motion restriction, we need to be able to isolate that mobility to whatever is most resistant to movement. Meanwhile, locking down extra motion, usually next door. So when I treat a person who's got a stiff glenohumeral joint, the ball and socket joint, I got to be really careful when I mobilize or stretch them that I'm not letting that shoulder blade slop all over the place. Because if something's not moving, something else is moving in its place. Just give you a second to digest that. It's really important. That's why we made an objective out of it. Okay? So if we want to get a little bit more mobile, be able to reach overhead so we keep our joints healthy and balanced, we have to have parameters. Here they are. We're going to do a little bit of a self-treatment lab here. So we're going to talk through joint mobility, we're going to talk through stretching, and then I'll yammer on about the last couple bullet points. So, because those who use a wheelchair, and especially propel, often keep shoulders forward, and this is a good position for doing lots of other life things, over time, the muscles that are used for forward reaching and pushing get stiff, get short, become less resistant to moving in the opposite direction. So, if this fits you, and it fits most of my patients, matter who they are. We need to get their joint movement a little bit better first before I ask them to go and stretch their pecs. So, do you want to talk through how you do the shoulder
You can
mobility?
explain it.
Okay.
Yeah.
So we got the ball kind of hanging on a socket. I like to have my patients visualize it as a golf ball sitting on a golf tee. That's the about proportions of the ball and socket joint, but turned on its side. So stable. So the ball is right here. And the more we're forward shouldered, forward head, forward everything, that ball starts to drift forward of the socket. So if we're having discomfort or pain in this area, sometimes, maybe I don't punch my microphone, sometimes guiding or gliding the ball back that away helps tremendously. And more surface area on the front of the shoulder is better than less. Probably rather be stepped on by a full loafer versus a stiletto heel, yeah? Loafer, right over the front of the shoulder. Keep your arm relaxed. And then you're just going to go, like a little paddle, straight back. And you're not going to feel like you go very far. I feel like I go about that much, maybe a centimeter, maybe. And I can push back and hold, especially if my body goes, oh, yeah, you just do that. Yeah. So we can just hold this. Or we could do a little oscillations, little wax on, wax off. Okay. About 30 seconds. Then take 30 seconds off for your hands. If you don't feel like you got great control of your fingers, heel the hand works great. Directing another human works great. Any tips that
Yep,
you
I like it.
You like it?
You got it. Yep.
Cool. So let's say joint surfaces are slipping and sliding and moving everywhere and you're feeling like a nice greased hinge. Now let's talk about flexibility. And this is where I get into my controlled mobility shtick. So we're going to all try, and be a little nice to your neighbors so we're not smacking each other in the chest. We're going to try to stretch our chest tissue, our pecs. Now, these pecs don't live in a vacuum. All their tissue runs all up into the neck and head. And stiffness in the pecs can also influence our rib cage position. So if we're going to stretch the pecs, we got to lock down everything else. You guys ready? Yeah? No?
Yeah.
This isn't a dictatorship. not entirely. Okay, so easiest way to stretch the pecs is to just open up the arms as best you can. If this feels way too stiff, you can get a little bit of a goalpost type position, or if arms don't like to be on their own, we can just kind of give our little beach pose and open up like that so your arms can be rested on your head. Now, if I just open up my arms with reckless abandon and my abs are weaker than my chest, they are, I'm just gonna stick my chest out. And I'll still feel stretch, but at the end of the day, I'm probably stretching my abs more than my chest. Does that make sense? Okay. So before we go into, give me a hug, drop your front lower ribs down. I'm thinking about orienting my imaginary umbrella towards the ground. Or I just need to feel that I'm situated against my backrest. I need to feel a lot of real estate back here, and I got to keep my back planted on my backrest. Now that you can feel your abs or feel a lot of real estate of your backrest on your back, now it's time to stretch. So now see how far you can go, opening up your shoulders, maybe squeezing your back muscles. And I'm already kind of at my limit right now. If you're feeling pretty flexible, we can add in pulling the fingers and wrists back to stretch all that connective tissue. And if we want a little bit more, we can lift our chin and pull our head back a bit. And now we're stretching the pecs.
But keep your abs down if you can when you tip your head back. Because
What
I
she
notice
said.
immediately my rib cage goes up.
Okay?
Yeah.
So for best results, you got to consider what are your goals. If we're trying to get more motion in the shoulders because our joints are stiff, we want to do our joint mobilizations or have someone do them to us right before we move. What's the use of opening up new movement if you then don't use it? The body is very use it or lose it. It's very dogmatic. You don't get to negotiate. Once you do movement to your system, use that movement. If, however, you are looking to do sports, do an intense training session, weightlifting, anything involving rapid, powerful, shortening movements of your muscles, you don't want to stretch them to bits before you get them short again. Does that make sense? Again, very, very specific with the body. You got to get the messaging right. So if I'm going to go and do heavy overhead throwing med balls, I don't want to go and stretch everything. I'm not going to be able to produce as much power. I'm not going to feel like I did anything with that session. Consider the effects of stretching in terms of reduced force production can last up to 40 minutes after the stretch, which is awesome if that's what you're going for. But if that's not the end goal of the day, just consider your timing. Just do your stretching after your workout when you're still warm. Does that make sense? Y'all smelling what I'm stepping in? Yeah? All right. Boom. All right, so let's say we got at least a little bit more sense of movement. Maybe you're already formulating a little plan. Get yourself a little bit more pain-free, good overhead motion. Once you're on your way with mobility, you can then start to think about moving your shoulder under load. And this, kids, this is where the magic happens. It is one thing to get mobility, and that in of itself can make a huge difference on pain. But when you can start loading that joint through its range of motion, the brain takes load seriously in a way that it doesn't take anything else seriously. It's where skills get acquired faster is under load. It's where that representation of our body and our brain gets sharpened even better is when we're under load. It's where our bones do better is under load. Our digestive tract does better when we put our skeletal muscles under load. So we love weight training. We want y'all to weight train in whatever capacity that looks like. We like the idea of getting pumped up because muscularly balanced shoulders and strong shoulders, where you built up your armor a bit, are much less likely to be injured, no matter what you're doing and no matter who you are. Resistance training is going to improve mood, metabolism, and your overall strategies for movement. Again, you're going to acquire movement skills faster when it's under load, a little duress. If you're a novice to weight training or strength training, you can see results just one time a week and you can do it at home. You don't need to go pay gym fees. You don't need to go and do fancy stuff. As long as you have a routine that's specific and works for you, one time a week is all you need to start with. I am very much like to think of myself as a lone wolf. I'm a pathological introvert, and when I do sports or weight training, I'm not going to the gym to socialize and make friends. And yet that's what happens. When you're in an area with great culture and like-minded people who support each other, you come away with a stronger network. And I think this is a big thing that contributes to improved mental health and mood when it comes to resistance training. Plus, you feel like a warrior when you're done with it. That's pretty fun. And again, more specific to shoulder pain, there are various different strength programs for the shoulder available in the research literature, all of which demonstrate an effect significantly on reducing shoulder pain symptoms. And anecdotally, it's a lot easier to get through life when you're strong. And it's really fun. So we want you to get excited about getting a little pumped up. So this slide includes recommendations to improve the muscular balance of your shoulders. So again, there's a lot of rolling and spinning happening in that shoulder. And we want a precise spin because it's really crowded in this area. Everything has to move perfectly. And so all the muscles that go up need to be balanced by all the muscles that go down. All the muscles that rotate us in have to be balanced by all the muscles that rotate us out, and so on and so forth. The last thing we want is for you to go in and just jump into a weight training program in an imbalanced state, because that load will just strengthen the imbalance. And then eventually rehab's going to take longer, and no one wants that. So the first couple bullet points are what current research recommends. Any strength program, it can look any way you want, but it should ideally include a couple of these ideas. Multiple effective programs in the literature all recommend strengthening the back of the shoulder while stretching the front of the shoulder. Multiple studies recommend resisted external rotation. This is external rotation. This is external rotation. This is external rotation. Okay? This helps get a little bit stronger the rotator cuff, balances the arm's tendency to be maintained in an internally rotated position for life activities. Adduction, bringing the arms into the sides, is also recommended because using a wheelchair usually requires the arms to be a little bit out. So working flexibility into this full adduction range and then strengthening it is also recommended. We also recommend working again towards pain-free, loaded, weight in hand, controlled mobility to balance the significant downward pull of the latissimus dorsi, or the lats. And that's the big bat wing muscle along the back of the armpit. It goes from the arm all the way down to the pelvis. It is a huge muscle. It helps with trunk stability. It helps us climb, pull, push, down, anything, okay? The only thing it really doesn't do is stabilize your shoulder. So if we're using our lats a lot to push down, to pull down, or pull up, you got to balance it, go in other directions, guys. That's why we're big fans of going overhead. There's a lot of studies that say, don't do it, don't reach above shoulder height. But we also already know that if we don't reach above shoulder height, the arthritis fairy is going to visit us faster. So balancing your muscular forces is the assured way, long term, to maintain and improve the quality of your overhead range of motion, balance the downward pull of your stronger muscles that you're going to be using for propulsion, for transfers, for regular life activities. Because the lats are a huge trunk stabilizer and they pull us into extension, challenging the abdominals, we also recommend a strong emphasis on including the abdominals in all that you do. The athletes that I coach and the patients that I treat all know every movement they do is a core movement. Everything should involve the abdominals or some way to manage externally or internally good alignment through the trunk, because the trunk is the foundation for the shoulder. Now, if you have good voluntary control of your breathing, but not great voluntary control of the arms, we can still create balance in that shoulder by addressing the breath. 24,000 repetitions per day is how much we breathe. That is a big pump mechanism working. It affects our viscera, it affects our musculoskeletal alignment, and it affects our muscles getting stiff or short or weak or strong over time. So see a therapist about improving your breathing strategy so that just the use of a good diaphragmatic strategy will give you good stability and create a great foundation for your shoulder over time. This slide is not so much about rote physical strength, but about the path we choose for movement, which is, I would argue, as important as anything else I've said. This goes beyond mobility, this goes beyond strength. This is about how one organizes and coordinates their movement. Variability of movement means performing, say, an overhead reach when you need to perform a reach, and do it within whatever constraints the context provides. So if I'm trying to reach up onto a cabinet and it's just a little out of reach, maybe I could twist or move and grab it with 2 fingers and then pull it down. And that's going to look different than if I'm pulling a plate off of a shoulder height shelf. Does that make sense? Because every movement that we do is, or every task that we do every day is slightly different than the task that we had to do the day before, because I inhabit a different system today than the system I inhabited yesterday, because I have more experience today than yesterday, Jill. I should move differently every time. And our elite athletes show this on a turbo level. Athletes never take the same road to achieve their movement, ever. And that variability, that variety of movement, keeps our joints healthy. Conversely, individuals who perform very repetitive movements, and I'm not talking the same, just going overhead, it's I'm going overhead in the exact same way, the exact same path every time, that's where we get into repetitive movement overuse territory. The very active moving overhead or reaching behind your body is not a bad thing, but if you do it the same way every time, it's going to end up bad for you. Just like elite athletes who are high performing never make the same movement twice, people who, again, perform stereotypical movements end up with a higher risk for pain. Ambulatory individuals with knee, shoulder, and low back pain demonstrate less variability in movement than their pain-free peers. We also know through a pilot study published a year ago, there is reduced variability of movement for those using manual wheelchair propulsion techniques when shoulder pain is present. We don't know if one is causing the other, we just know they occur together. So correlated, not necessarily causal. And our old friend fear avoidance, I can't do that, it'll hurt me, will also reduce your variability. Because then you'll start saying, well, this movement's good and this movement's bad and I can't do this and I can only move like that. And now your world gets narrower and narrower and narrower. Variability is good for everyone. Michael Jordan is the athlete that I talk about all the time when I talk about variability. He was the very first basketball player to perform a over-the-head dunk, reverse dunk. And it just popped out during a game. And after this game, presumably they won, because the Bulls always won when Michael Jordan was on board, he was swamped by reporters and everyone wanted to know, where did you learn this and when did you practice this and why did you pull it out tonight? And he said, I don't know, I've never practiced it. It just seemed like the right thing to do. That's variability. So, y'all's goals, let's get a little of that Michael Jordan perspective in your life. Be Michael Jordan. Don't do the same thing twice. Change your routine. Add balance to your weight training program, as I've already talked about. Also think about applying variation across all your body systems, different workout and self-care routines, but also take a different route throughout your living space throughout the day. Don't do the same path every day. Try meditation, try different podcasts, brush your teeth with a different pattern. Notice if you have a preference for chewing on one side of your mouth. These are all things that if we can just insert a little variability here and there, that gives our systems a more durable sense of robustness rather than fragility, because we're using the same tissues over and over again. I've been citing research literature, as has Julie, that's been published principally in the last 5 years, because we're trying to give you an update here on maybe what you don't know. But I did want to spend a few minutes acknowledging a seminal article that was published in 2011. It was the first of its kind, investigating the effect of a basic home program on shoulder pain for individuals with spinal cord injury, and this is paraplegia. The program is called Strengthening and Optimal Movements for Painful Shoulders, or STOMPS. This program is cited extensively in the research literature and, to our knowledge, is still being utilized by many clinicians, at least as a foundation for shoulder programs. We like this program. It was great in that it not only accounted for flexibility, strength, and movement education. It wasn't equipment heavy, it wasn't lengthy, it could be done in the participants' homes. And best of all, it worked. The researchers found a significant reduction in shoulder pain with practice of the program. But search for truth is messy. This wasn't a perfect study. So we can't look at this as the perfect foundation for rehab. Lots of limitations. Small sample sizes, which we could probably spread across every study. Home program consistency of the participants was determined through self-report, and the program wasn't performed as consistently across all participants as it should have been. We don't know because there were several levels of intervention. Was it the flexibility? Was it the strength? Was it just moving? Was it movement education? Was it some combination of all of those that led to pain reduction? So we can't say, take the flexibility piece, take the movement education piece. That's what you need for your shoulders. We just don't know. There was too much to account for variable-wise. And even when pain was reduced, the researchers found that that's all that happened, which was good, but it didn't take that next step into, did the participants of the study return to community integration? that dream beyond a dream that all therapists want. Everyone goes back to their normal activities, everyone goes back to work, everyone goes back to sports. That didn't happen at all. But the pain went down, so that's good, but it's clearly not the whole story.
I have one thing to add to this because it makes me kind of cranky when I read the recommendation. Because there's an appendix and it says to avoid bumpy terrain and to avoid incline. And to anyone living in Seattle, that's saying don't leave your house. Just stay inside. And maybe that's why the activity participation didn't increase, because you can't go outside if you're going to avoid bumpy terrain or inclines. So I'm sure they had the best intentions with that recommendation, but it really, that's the kind of stuff that keeps me up at night, thinking that maybe someone is making recommendations like that. I'm like, please go outside. Please try a hill. Maybe ask a friend to push you up the hill if it's too hard, but please go outside.
Make your world bigger, not smaller.
Please.
Bigger. So building on this foundation, it's been 8 years since this was published. We know more now than we did 8 years ago. So this is our attempt, this slide, at trying to capitalize on what we know and how to build on the foundation that the STOMP study first came out with. So as previously stated, and Shakespeare repeated all of his important points, so I can too, just so we're clear here. All right? So we know, and this should be almost, yes, she said this, there is a relationship between mobility and stretching of the front of the shoulder and strengthening of the back. We know that our external rotation is good for us. And we also know that the shoulders are used frequently in this position for mobility, propulsion, or other life activities. Knowing this, we say, and this is our recommendation, not the research, just so you know, this is ours. We say keep the chest stretch that STOMPS recommends. It's fine. Or do the one that we just did. That's also pretty good. Maybe discontinue the posterior shoulder stretch, which is the crossbody stretch. Let's try that real quick, because this is another little trigger stretch for me and Julie, okay? So if I'm gonna stretch my arm across my body, to try to stretch the back of my shoulder, I gotta do it without my shoulder blade coming off my body. So before we even bring our arms up, I'm setting my trunk, I'm setting my abdominals, I'm getting my back against my chair, I'm getting my trunk happy, nice cylinder. Then I'm keeping my back muscles on, my traps on, to squeeze my shoulder blades together. I'm gonna keep that shoulder blade locked down on my back. And when I feel that my shoulder blade isn't moving anymore, now it's time to stretch, and that's as far as I go. So what are we doing when we're doing this? Stretching the traps. That's not good. So that's why we say, maybe consider, unless this gives you just the best feeling in the world, maybe don't need it. You need this, but maybe not this, okay? We also suggest adding a lat stretch, since I've already soapboxed about how stiff and strong and powerful and big that sucker is. Maybe stretch it, since you're using it so much. The upper trapezius, these guys, where we all carry tension, maybe you don't need to stretch that either. Maybe your tight traps are because they're being pulled taut. Maybe they're already on stretch. So if you look in the mirror and your collarbones are not making a T, but making an A, if your shoulder slope looks like an A versus a T, baby, your lats are winning. And if you also have upper trap tightness and you're stretching and lengthening them even more, that just gives your lat more rope to pull down on. So I tell people who've got long, overstretched upper traps, one, stop stretching. For the love of God, stop stretching. Stop it. Secondly, you got to strengthen them and stiffen them. You got to give them slack so that they stop screaming at you. Now I'm going to share a little secret with you guys from the fitness world. Not even the gym bros know this one. Upper traps, we talk about shrugs, right? Dumbbells in each hand, shrugs. To truly shorten the upper traps, those shrugs got to be all the way overhead. This is an upper trap exercise. So if you want to stiffen those suckers so they stop feeling like they're pulled on, you got to get your arms as overhead as possible and then get your shrug on. And now you know more than most people that go to the gym. You're welcome. With respect to external rotation, we love it. It's a good exercise. It is so dang boring. Who is so over rubber band exercises? Because I am 10 years over those. There's 100 different external rotation exercises. Choose more than one. You might stick with it longer than that. All right? So if you're just doing one, it's so boring. Add variety, add variability. Go on YouTube. I'm sure there's a million gym bros that would love to show you their rotator cuff exercises. Take them to your PT, sort it out, find a program that you can rotate through to keep your interest and get your strength up. Because, again, those shoulders like to rotate in, medial rotation, we have to consider muscles that will balance that. We already talked about how external rotators are helpful. There is one rotator cuff muscle that also medially rotates the arm, and that's the subscapularis. Beyond the scope of our lecture to talk about a subscap exercise, but know they exist, and it's all about control of the ball in the socket. We want to do a teeny tiny little muscle group exercise for that because the other muscles that medially rotate, pecs, lats, not stabilizers. Subscapularis, stabilizer. So if you or someone you know has the very common diagnosis of bicipital tendinitis or tendinosis or biceps or slap lesion or anterior shoulder pain, I don't care that much about diagnoses. If it hurts in here in the front, it might be because that ball's getting pushed too far forward. Subscap pulls it back. Okay? Again, work with your PT to create that balance. Pecs protract the shoulders. It's a great position to be in, but you got to get out of it. Serratus anterior, which is a muscle that also protracts, needs to work with the pec to do that motion. We like that because, again, the pec is a mover and a shaker. It does not stabilize. It will shear your shoulder half off. Serratus anterior is the suction cup that keeps your shoulder blade on your rib cage. We love serratus. It's also nice and linked up. It kind of holds hands proverbially with your abdominal wall. So doing a little bit of abdominal contraction is already lighting up serratus a little bit. Again, work with a therapist or maybe you have a personal trainer who knows you and loves you. Get your balance down. These are all muscle groups that I have seen clinically be very effective in creating balance at the shoulder girdle. Alrighty. So we're going to think about fitness now and think about that as like just weight training for your heart. Okay? So the next couple slides are going to be more for my numbers geeks in the room here. If you're not a numbers geek, just know that this is here anytime you need it. And you'll need it if you're trying to develop or repair your muscles, because your muscles can't repair at an optimal rate without good food, without protection, and without the heart fitness to feed them. Even if you're not working on heavy muscle training, you can get your hydration dialed in. If you're hydrated, your body is at least operating well there. Your metabolism's working on overdrive. If you're doing strength programs or sports, you're going to get a little bit more strength output than if you're dehydrated. So as I tell my athletes, pee clear. I'm not a registered dietitian, but I can tell you that what you eat and when you eat it matters, especially if you're working to improve your overall strength or working on repair or working in athletics. If you don't know what to eat, talk to a registered dietitian. Personal trainers can also be an excellent resource, especially those higher level ones that are used to working with individuals who are trying to get weight training competition ready. It's all about the nutrition for them. They'll talk your ear off about it. Now, from a cardiovascular health perspective alone, we got to be aware of where the obesity line is drawn. Okay? So we're going to talk just a little bit about the body mass index. Does anyone not know what the body mass index is? Does anyone want me to talk about what it is or why we use it? Anyone?
Yeah, I think we're
One?
here. Yep.
Awesome. I'm sure there's other people. It's okay to raise your hands. It's all right. The body mass index is a risk scale. It is population data that factors in your height and your weight. So it's how much do you weigh for how tall you are. And we're not worrying about body composition. It actually is irrelevant. at a certain cutoff of BMI, the body mass index, one is classified as obese or not obese. We care about this because at that line, the risk for cardiovascular disease skyrockets. Okay? This is not about body positivity or telling anyone that their bodies are bad. This is simple facts and physics. The bigger you are, the harder your heart has to work to feed all that tissue. This is why boxers and linemen die early, because they never worked on their heart fitness, and they are big guys, and that's a lot of load on the heart. They may have been fit at one point, lots of muscles, doesn't matter, it's a lot of load on the heart. So knowing your BMI, working with your doctor and knowing what that number is and where you fall in relative risk can make a huge difference on your overall health. But all these numbers were crafted in an ambulatory population. And it's not appropriate to take numbers in an ambulatory population and just sneak them on over to a niche population. It doesn't work. Fortunately, some recent studies have helped to retool the math, and we're hoping they did that math right. So rather than 30 as a cutoff for BMI, as in say the shorter I am and the heavier I am, the higher my BMI is. So the recommendation is, if this is something we're worried about, your cutoff for obesity is 25, not 30. All right? This is healthy for your heart, but it's also healthy for your shoulders. Less weight to move around with your shoulders puts less strain on the joint. Study after study after study shows that a higher BMI is correlated with a higher risk of shoulder pain and injury. I'm going to come back to the MET thing in a hot minute. A couple more numbers, exercise targets. Again, there's been a lot more retooling in the last couple of years, which is pretty lovely. We're still getting the numbers, okay? It's messy, messy search. One study looked at, can one who does manual wheelchair propulsion use manual wheelchair propulsion in a way that a person who ambulates uses walking every day for cardiovascular health? Can we do the same thing using a wheelchair? So through a lot of math and physiology and all sorts of fun trickery, they came up with this number. If you are going to use manual wheelchair propulsion for fitness, one needs an additional almost 45 minutes per day, every single day, to get the cardiovascular benefit. And that seems like a lot to me. And that also makes me as a clinician a little bit worried that diving into a program like that, while healthy for your heart, may push many people over that thin, sometimes tenuous line of enough movement through the arms to get your work done, but are we going into that category of now it's too much, and now we're going into overuse? And that's just my worry. Perhaps a better way to think about it is, let's up the intensity and drop the time. So adjusted exercise guidelines for spinal cord injury, moderate to vigorous intensity activity, 20 minutes twice a week. That is dropped from 30 minutes. And for strength exercises, the recommendation is twice a week, 3 sets of exercises, 3 groups of exercises per each major functioning muscle group at a moderate to vigorous intensity, an additional twice a week. So if you just go with this for fitness, that's an every other day program, hopefully of a lot of variety. The moderate to vigorous intensity leaves a little bit of room for interpretation, though, so that's why I wanted to go back to the MET thing. So this is the bottom bullet of this slide. MET is a metabolic equivalent. It is roughly equivalent to the amount of oxygen one is consuming per kilogram of body mass per minute time of exercise. This is what exercise physiologists just hang everything on, right? So it's just a measure of effort, and there's scales that you can find easily. Just ask Dr. Google about what a metabolic equivalent list looks like. And again, metabolic equivalent list was developed by ambulating researchers. So it goes from sitting at a computer and doing typing as 1.5 metabolic equivalents to jogging at 6.8 miles an hour, which is not jogging, at 11.2. Moderate to vigorous is 3 to 6 is about moderate MET intensity, 6 and above is vigorous. So Go online, ask Dr. Google, there's a million MET scales out there. Just know that in the spinal cord injury population, we can drop one metabolic equivalent from 3.5 to 2.7. All right. We love sports. We love them so much. We like watching them. We like doing them. I am legitimately my best self when I do sports. And I would love everyone in this room to feel the same way. I like working with my teammates to create something bigger than what I can do on my own. And I especially like that I have a tangible reason to dial my life in. I apparently can't get it together when I'm shooting for this vague notion of wellness over the lifespan. But if I've got a competitor to beat in a month, you better believe I'm keeping track of my diet, my sleep, my hydration, my protein. I'm working my mental game. I'm doing meditation. I'm working with my trainer. I am dialed in, baby, because I know I can use my competitiveness to get myself into gear. But the idea of being well just sadly doesn't sell it for me. So for sports, that keeps me honest, and it keeps me well, and it keeps me healthy. And I think that works really well for a lot of people. Even if you're not a competitive freak, you can still try a sporty activity, something higher intensity, something that's variable and challenges your system to adapt and get stronger. And again, one of the best things about sports is it helps with that whole community integration piece that therapists love talking about. If you're a little concerned about, well, sports, injuries, and there's no difference in the rates between shoulder pain in the sedentary wheelchair-using population and the sporty wheelchair-using population. No difference at all. We also note that there may be even a protective effect for shoulders. Okay? And this is actually specific research for the tetraplegic population. Protective effect. We know that this positively impacts mental health. Again, there's that group effort. That's why CrossFit works. You put a bunch of people in a room and make them miserable together, they're going to be battle buddies. That's your social connection. It's, you know, it's good misery. Just, I'm not selling it well, but it also can improve employment status, community reintegration, and social relationships. So it's everything that we want it to be. Now, we know that self-care and maintaining general wellness really does take a heroic effort. It absolutely does. But you shouldn't ever feel that one has to do it alone. So we're going to wrap up with a couple slides just to help you determine when to seek care and maybe when you can kick the can down the road a little bit. This is a case study we found, and this is essentially my fantasy as an athletic trainer come to life. This is what we all want for our athletes. It's our goals. This involved a female para-triathlete who started experiencing shoulder pain that just wasn't going away. It had popped up a couple other times in the past in her training, but had gone away, and so no one worried about it. In this case, it turned on and kept getting worse. This athlete, as she was preparing for a competition, had no interest in stopping preparing for the competition, so she immediately consulted her care team, was worked up by the doctors on board, was diagnosed with a slap lesion and a rotator cuff tear. So some muscles got tore up. A slap lesion is where part of the biceps tendon, which connects to a big cartilage ring in the shoulder, starts peeling away that cartilage. So it peels the cartilage off the bone, which doesn't sound too functional when your cartilage starts rolling off your joints like peeling paint. But that's essentially what was happening. This sounds scary, right? This sounds like a career-ending injury to me. So immediate treatments, cortisone shot, mellow everything out, reduce the pain. Physical rehabilitation that focused specifically on what she struggled with, stabilizing her shoulder blade. Apparently it was slopping all around too. Maybe she was doing too many cross-body stretches. I don't know. They also had her do some shoulder external rotation. So if it's good enough for a para-triathlete, it's good enough for all of us, all right? Don't have to be a rubber band, just do your external rotation. They also reduced her training volumes temporarily, and only the training activities that were causing problems. Everything else, full bore. In 2 weeks, she reported a 90% reduction in symptoms, which is mind-blowing. 2 weeks and 90% better. That's basically 100% for an athlete. Why did this work, and what can we take from this and apply it to us mere mortals? So what worked for her? She went to her care team immediately. Once she realized this wasn't like the other times, she got help fast. She utilized multiple members of her healthcare team. Physician to work her up, someone to run the MRI, someone to interpret the MRI, someone to give the cortisone injection, someone to do the rehab program, someone to administer the rehab program, and someone monitoring everything. That's a big heroic group effort. Her activity was reduced, but not eliminated. And this is so key. This is active rest. She didn't just stop, and that change in her activity allowed her to stay in peak condition, peak strength, while she mellowed out on provocative activities. She completed an evidence-based and resistive program that focused on her problems, not just a general move. And it was progressed specifically every other session, harder and harder and harder, forcing her system to adapt. And, which makes everyone's life easier, she was already in peak shape. Everything was already running on all cylinders, so all she had to do was focus on repair. That's a lot easier when your system's already running good. So this leads to what constitutes early intervention so that we can utilize our healthcare team as rapidly and efficiently as possible. This is a little binary thinking, but in general, musculoskeletal pain has two main roots. The, oh no, I felt it go, I felt it tear, I was reaching and then I pulled it down and I don't know what happened and now my shoulder's swollen and I can't move it. You know what happened, you can isolate it, maybe you felt something go. In that case, especially if it's a big thing, seek immediate care. Maybe don't call for transport, but make an appointment with someone you trust, an orthopedist, physical therapist that knows you real well, and get someone's eyes on it. You might need imaging. Maybe you may need imaging just so you sleep better at night. That's appropriate. Get someone's eyes on you. And then you're going to do what anyone else does when they get hurt. You're going to reduce your activity, protect the area. You're going to distinguish between what's pain and what's discomfort or stiffness. And you're going to work through any range of motion or task where it's not painful. And then slowly progress back to normal. Research recommends limiting weight bearing through the arms as much as possible as you're slowly getting back to normal. And then after about 6 to 8 weeks, most people, if you do this right and you don't go back too soon, too much, most people get better. Normal orthopedic problem. And that's what 6-week regression to the mean means. The mean is your basic status quo function, all right? If I get hurt, I pull something in my shoulder, I get a sprain or a strain, and I just let things mellow out and do some movement. Around the 6-week point, no matter what activity I choose, maybe I'm using a hand cycle, maybe I'm doing some overhead weight training, maybe I'm doing some modified Pilates, all of it's going to work. Because between the 6 to 8 week point after injury is when your body is going nuts with the repair process. Tissues are being repaired, collagen's being laid down and strengthened. That's why back in the day, physical therapists thought, oh, we'll just have them do some rotator cuff exercises with the band and do a little stretchy McStretch and, oh look, they're all better. It didn't matter what they did. Most people, when they're tired of everything hurting, it's usually around the 6-week point. And when they initiate care, it's all magically better because their body was doing it. So the point is, it doesn't matter what you do. The point is that you ease in, and within 6 to 8 weeks, you should feel like you're turning the corner. If you're not, initiate treatment again. Figure out why things aren't going as fast as you want. Why am I not regressing to the mean? You should ask your doctor that. And then record it and send it to me. Now, when we're recovering from a trauma or an acute injury or an oh no moment, sometimes we don't progress as conservatively and carefully back to activity as we should. And sometimes life demands that we can't. When we do too much, too quick, too soon, or we make a sudden change in our activity, that's when the, that's funny, I didn't feel that yesterday feeling comes up. And that's the pain that just creeps up on you. It's insidious. There's no known mechanism. We don't know where it came from. It just started up one day. So in either of those situations, you want to take a step back, look at the forest from the trees. Did I make any significant changes to my activity or my routine lately? Is my body reacting to something? Do I just need to pull back? Have I actually stopped my activity too much in the last couple weeks and I'm stiffening up, and that's the problem? So if you can identify something that's out of the ordinary, do it, and then stop doing that thing and see if your symptoms change. If you know that you have flexibility issues or strength issues, tackle those. Just dabble, see if it works. You might be that person who just needs a little bit of basic movement. You might be that perfect stomps person that gets better with a basic, non-specific program. But if things don't start changing in 2 weeks is just my own cutoff, things don't start really feeling like you're making change in 2 weeks, please get a PT or an OT or any form of a movement expert in a room with you so you guys can troubleshoot this, because it might be deeper than just a little something.
All right, and so we laid out this slide as just kind of an ideal start and end to the injury process. So you're living your life. We talked you into trying some sports and some fitness, and you're still hanging out with your friends and you got your social connection. But then, injury happens. What do? It happens to all of us. Manage the pain and inflammation. Modify your activities. Rest if you can, as much as you can. And that might mean, I know for wheelchair users, you can't totally rest. But do the transfers you have to do, and don't do the transfers you have to do. You know, you're on the couch and you really want that candy bar, ask somebody else to get it. Or maybe skip the candy bar. That's our advice.
That's okay too.
Yeah. And note that social life and connection with others should be an ongoing part of wellness, with or without existence of pain or injury, as well as all the other aspects of self-care that we mentioned. And Jill covered initiating contact with a healthcare provider. It might be your MD, it might be your PT, it might be an OT. If you're not happy with the care you're receiving too, seek somebody else. You might not like somebody's style. Just because you have a spinal cord injury doesn't mean you have to go to a spinal cord injury expert. Maybe they're the right person, or maybe they're not. Just go with what works best in your life. And depending where you live, you might not have a spinal cord clinic to go to. So it's good to keep your mind open. And then utilize your entire medical team if it gets to that. And that might involve getting a counselor, psychologist, or someone on board too if you are having some of those kind of brain games, I was calling them, some of the things where your brain really is interacting with how you're feeling and what you're able to do. Don't jump back in at 100%. When returning to fitness, go low rep, low resistance, and conservative return to activity. You know, don't take 2 weeks off from the gym and then go do the hardest day you've ever had. Like, that's not a good idea, and that's not helpful for injuries. Many lengthy injury states are due to training errors, like jumping back in too fast. It's hard, but we think baby steps are good. All right, well, we hope you all learned a lot tonight. And in case anything that we talked about sparked your curiosity, we did put together a list of further reading, and that is in the slides. We tried to put together some stuff about pain, some stuff about like athlete mental game, just some mental health resources, and kind of some sports analogies and some coaching. And it's kind of it's a nice mix. I think it might surprise you. And we also included our email addresses in case you have any questions you don't want to ask tonight, or if you're watching this online later and want to know what's going on. And we also can open it up to questions now.
Just remember to repeat.
Yes.
Mm-hmm.
Anybody have a question?
We covered everything.
Oh, you're experts now.
Chris has a question.
So the question is, for those who don't have voluntary arm movement, are there recommendations for healthy shoulders for this population? And the answer is a resounding yes. There's a tremendous number of studies that have come out in the last few years that say any movement, even if it's someone's moving the arm for you, is going to give the joint nutrition, it's going to help with repair and keep the tissues healthy. So even if it's passively done, you're still going to get the beneficial effects of mobility, even if you don't have voluntary control.
And supporting the arms appropriately can be really helpful too, because your arms are heavy, even if you don't have muscular arms. The weight of your arms is heavy. And so that's stretching, pulling on those traps all the time. So even just putting a pillow under each armpit, which maybe don't do at work, but that's something you can do at home.
That's true.
Or if you need to have arm rests or whatever the situation is.
Right.
But just getting some of the weight off of, instead of having your arms hanging heavy on your body all day long.
Okay, you want me to go first?
Repeat.
Okay,
Yeah.
so the question is, what's the difference between an ortho and a neurotherapist, and maybe how can we work together in a better way to coordinate care? Would that be a good summary? So I'm technically considered an orthotherapist because I work in an outpatient orthopedic clinic. My main limitations is I don't have a good big mat table, and so I'm restricted if a person uses a wheelchair to using a up and down table, but that's one of those little narrow guys. So I'm personally very restricted by my equipment in the clinic as to who I can see and what I can do. I take, for almost everyone, pretty much a standard orthopedic approach. It looks orthopedic, but I'm also utilizing as many neurological techniques as I can. Mini soapbox, I really struggle with the distinction between like an ortho or a neuro or your specialty or this. I want all therapists ultimately to be really good generalists and just know the whole system, but artificially we have to be changed into inpatient versus outpatient versus whatever. I think the value of an orthopedic physical therapist is that we're trained to get a little bit more granular, looking at the joint mobility, but then also being able to look at the forest from the trees and go, okay, well, are they even utilizing that joint mobility with an effective strategy? So I'm looking at patterns too, but I'm looking at orthopedic patterns. I think that in terms of like neurologic versus orthopedic care, I think it's a much blurrier line, to be perfectly honest. I think if we actually stop creating distinctions, we'll find that we kind of have the same training, we have the same beliefs, but we're just stuck in different buildings. And we end up having, oh, you have to work on transfers and I'm gonna work on fitness. But I think every therapist needs to be working along that entire continuum. I would say as soon as you run out of a tool and patient's still uncomfortable or problematic, call someone, and I would do the exact same thing. I hate the idea of thinking I am totally responsible for my patient's total well-being and care, and I am relieved to know that there's neurologic therapists and seating experts and the whole community here that can help me with that, because my God, am I not good with that. But I'm really good at looking at shoulder mechanics and neurological control, so I stay in my lane and surround myself with geniuses, and I hope that answers kind of slightly.
And I think
you want to add?
One thing I would add is when we started creating this talk, kind of one of our titles was treat like an athlete, or treat them like an athlete, because I think sometimes, and I don't want to blame anybody for anything, but I think sometimes therapists don't always treat wheelchair users like that they're capable of living full lives, and sometimes you get that pep talk and sometimes you don't, and this is a whole other talk. But when you think about somebody's body, and imagine your patient is Michael Jordan and you want him to go do his slam dunks, so you want to do the best possible. You don't want to be like, well, here are these 7 TheraBand exercises that I give everyone, and do those. And I know we're so mean to we love TheraBand. We just don't like internal external rotation, I guess. The same exercise always.
So boring.
Yeah. But treating people like it's their career, because it's their life. You want them to be able to do as much as they possibly can. Because I don't think that there are really good strict protocols where these 7 things are going to make you better. It's just like with wheelchair seating, like everyone deserves a custom, specially focused thing. Like that's why we couldn't be like, get your chair set up like this, because it will be different for everybody, and it's the same with the care you provide. And I think lots of continuing ed. And all, like, I don't know if they have classes that are neuro rehab for ortho and vice versa, but
It's not good.
yeah.
It's not good. We should change that.
We'll work on that.
Yeah, next year. So you're looking for ways to be able to objectively measure body composition and track those types of measures over time as a measure of fitness? Right. Yeah. There's a number of ways that you can measure and track that. DEXA scans, of course, are great for bone density tracking over time, and there's a tremendous number of ways to get a good estimate on relative body fat percentage versus lean mass percentage. The gold standard is hydrostatic weighing, which is maybe not an option for some people because it involves being dumped in a pool and have you breathe everything out and hold it for a few seconds. So if there are accessible hydrostatic weighing companies, that's the gold standard. And there are a lot of hydrostatic companies that keep your results and you can just get nice readouts over time. Like they track everything for you. In absence of that, there's bioelectrical impedance and simple calipers that back in the day, a little pinch of fat. It's not the most accurate, but if you use the same technique every time, then you can track across time with that one instrument. So calipers is going to be the cheapest and the easiest, but highest error. Bioelectrical impedance is another one where it measures resistance across the skin, and it gives you a sense of does not, yeah. Yeah, does not need to be recalibrated was the question. Oh, I see, yeah. So what's the purpose of ranging above shoulder height? You're right. If you don't utilize a joint through its full available range of motion, the joint's going to start desiccating at the edges, and this is early arthritis. You have to create pressure, compression, and different forces within a joint to keep all the margins and edges of a joint healthy. It doesn't matter what joint we're talking about. So I feel very strongly, I'm not dogmatic completely about this, but I feel very strongly that whatever a joint is capable physiologically of moving through, we should be pushing for that within a symptom mitigated context. Like, I'm not going to push someone through what's uncomfortable, but in order to ensure that our joint surfaces, our cartilage that lines the end of our bones gets adequate nutrition, we got to go through different ranges of motion. So I take more of your physiologic orthopedic approach to range of motion.
So, very good.